And so we have Dr. Christopher Bowlus from Lena Valente, Professor and Chief Division of Gastro and Hepatology. So thank you, Dr. Bowlus.
Thank you. I think
Oh, yeah, that's right.
Yeah. Thank you, Tom, and thanks everybody and the organizers for having us back again. This is great to see everybody here. It's been a while. I've always enjoyed giving these talks and conversing with the patients with PBC and their caregivers. This is sort of the introduction to PBC talk. We're going to talk about treatment and diagnosis. And a lot of this is going to depend on how long you've had this disease. So if you've had it a long time, there'll be a lot of review. Some of it will be, new information, particularly if you've just been diagnosed. So maybe we just start with a show of hands of who's been diagnosed in the last year. Oh, wow. Okay, great. How about in the last 5 years? 10? More than 10? Okay. Those over 10, you can leave now. No, there might be something new here. Let's see. Okay. Let's see, where am I supposed to point this? Somewhere? There we go. Okay, just for full disclosure, the pharma I work a lot with to try to get new treatments to PBC. There we go. Okay. So let's just start with talking about some terms first because, you all know the term PBC, but do you know what it stands for, right? So primary biliary, used to be cirrhosis, now it's cholangitis. So primary, what that meant was it was sort of no underlying cause. I'm not doing anything, I promise. I don't. So no underlying cause. It's not secondary to something else causing this disease. So primary was the term given to that. Biliary just means it involves the bile ducts. And it used to be called cirrhosis, right? So it was primary biliary cirrhosis. And cirrhosis, in the general population, they'll think about alcohol-induced cirrhosis, which is common, but that's cirrhosis in the medical language just means a badly scarred liver. So it meant somebody that had this biliary cirrhosis, a bile duct-caused cirrhosis, but we didn't know what the underlying cause was. So it was primary biliary cirrhosis or PBC, and then it became clear that most patients with PBC don't have cirrhosis, so we wanted to change the name, so we changed it to primary biliary cholangitis, and cholangitis just means inflammation of the bile ducts. So it's a bit redundant to say biliary cholangitis, but it kept the PBC name. So that's where we got PBC, and this is an autoimmune phenomenon. That's where the body's immune system attacks itself. It's not supposed to do that, but that's what happens. And so PBC is a type of autoimmune disease that targets the bile ducts. We also have autoimmune hepatitis, and hepatitis is when we have inflammation of the liver, but the inflammation is directed primarily at the main liver cells, what we call hepatocytes, different than the biliary cells or bile duct cells. And so PBC is really an autoimmune cholangitis. That would be another term we could use, it maybe a little bit better, but we're stuck with PBC. But we need to know about autoimmune hepatitis because that's also something that may interact with PBC, and we'll talk a little bit about that. And the other term that you'll often hear and get confused with, and your physicians will often get confused with, is PSC, which is primary sclerosing cholangitis. So very close term, but sclerosing just means hardening of the tissue. So in PSC, they have hardening of the bile ducts and the larger bile ducts. So it's a little bit different. It's a very different disease. They both involve bile ducts. But the names often get confused. So just to be clear, PBC and PSC are quite different, even though the terms are oftentimes very close. So PSC, they have the sclerosing of the bile ducts. Oh, okay. I'll just say next slide. Great, thank you. Yeah, so just if we look at this in sort of a larger schematic or illustration, just showing where PSC, autoimmune hepatitis, and PBC affect the liver itself. So PBC, small bile ducts, autoimmune hepatitis, the hepatocytes or liver cells, and then PSC, the larger bile ducts where it causes that hardening, sclerosis, and stricturing. Next slide. And in terms of the characteristics of these diseases, so autoimmune hepatitis is a disease that affects predominantly women, about 3 to 2 in terms of the ratio. We make the diagnosis based on the presence of a hepatitis and serum markers like anti-smooth muscle antibody, which isn't quite as specific as the anti-mitochondrial antibody we see in PBC, but a combination of all those criteria gives us the diagnosis of autoimmune hepatitis. PSC is unusual in that men are affected more frequently. It's associated with inflammatory bowel disease. The histology looks different, and we diagnose it on what's called a cholangiogram, an MRI, and that's what that black and white image is there of the stricturing of the bile ducts. And then we have PBC, which is, if you look at the audience, you know, is about 9 to 1 in terms of men to women. We make the diagnosis based on the anti-mitochondrial antibody. There are some associated other diseases such as Sjogren's. And the biopsy we'll talk about a little bit later has a very specific appearance as well. Next slide. So now that we've got kind of an understanding of the autoimmune liver diseases, let's delve into PBC and how we make that diagnosis. Next slide. And just for your reference, there's guidelines, a little old now, from 2018, but it's got a lot of very specific recommendations that are good for your reference or your physician's reference in terms of how to manage and diagnose PBC. Next slide. So making the diagnosis of PBC tends to be pretty straightforward when we talk about it, but we're going to go over a few different scenarios that make it a little bit more complicated. But generally, you need 2 of 3 criteria to get the diagnosis of PBC. You need an elevated alkaline phosphatase, and that's how most people present initially. You need a positive anti-mitochondrial antibody or a specific anti-nuclear antibody, and we'll talk about those in a minute. Or if the anti-mitochondrial antibody or these other antibodies are negative, a liver biopsy that's consistent with PBC. So typically what we do is someone comes in with an elevated alkaline phosphatase that might have been observed because of someone had symptoms or just routine checking of liver tests. We want to exclude other sources of the alkaline phosphatase. It can be elevated from bone disease. Rule out obstruction of the bile ducts, because that's more common than PBC for sure, so an ultrasound, something like that. And then we get the AMA and the anti-nuclear antibody, or ANA. And then based on those results, if they're positive, we have our diagnosis. If not, then we have to consider a liver biopsy. Next slide. So if we think about the most common pathway to getting diagnosis of PBC, it doesn't require a liver biopsy. How many people have had a liver biopsy for diagnosis? Wow. Okay. Most people do not need a liver biopsy to make the diagnosis of PBC nowadays. So we have an elevated alkaline phosphatase, we have no bile duct dilation, we check the AMA, the anti-nuclear antibody, the AMA is positive, you have PBC, full stop, no biopsy, nothing. Next slide. Okay, so instead your AMA is negative, but your ANA is positive. Then there are these specific anti-nuclear antibodies, SP100 and GP210, that we can test for. If those are positive, you have PBC, no biopsy needed. Next slide. Now, if the AMA is negative, the ANA is positive, but the specific PBC antibodies are negative, now you need a biopsy. And what we're looking for is a very specific feature on the liver biopsy shown here. And so over on the left side is the kind of pink-colored liver cells, the hepatocytes. All those dots, those black dots, those are inflammatory cells. And in the middle, that tubular structure is a bile duct. And that bile duct should be nice and round, and those cells should be nice, kind of lined up in a full circle around it. And you can see that this one, or hopefully you can see, maybe not from back there, there's some of those black dots, those inflammatory cells invading into the bile duct. And so that's the sort of lesion we're looking for on your liver biopsy to show that you have PBC. Next slide. And then similar to the last slide is if your AMA negatives, your ANA is negative, you go straight to liver biopsy, and again, you get the diagnosis. So those last 3 kind of diagnostic pathways we were just talking about, that should only account for about 10% of patients with PBC that need a liver biopsy or need these specific anti-nuclear antibodies to get diagnosed. Most physicians probably don't know about the specific anti-nuclear antibodies. They have to be special ordered. So they may just get the AMA and then go to biopsy if it's negative. Next slide. So when you put it all together, it looks kind of like a crazy roadmap, but this is sort of what we should be thinking in our brains about how to get to the diagnosis of PBC. Okay. Let me just say, I was going to stop in the middle to take questions on diagnosis before going on to treatment. So if you start thinking about your questions related to diagnosis, we'll try to answer some of those before we get to the end, since we've got a bit of time. Next slide. So there are a few scenarios to talk about that don't quite fit that paradigm. The first is an AMA positive with a normal alkaline phosphatase. I don't know if anyone here has had this, but we see this occasionally when a family member gets tested for AMA, someone is in a rheumatology clinic and the rheumatologist for reasons tests the AMA. And we know that AMAs can occur rarely in individuals with no evidence of PBC. You can find it in healthy blood donors. Patients with autoimmune hepatitis, about 10% of them will have a positive antimitochondrial antibody, but have no evidence of PBC. And so the question comes up in these rare cases is, what does it mean if you have an antimitochondrial antibody, but your alkaline phosphatase? And I should point out here, ALP means alkaline phosphatase. If your alkaline phosphatase is normal, is that just early mild disease that we haven't diagnosed? Does it mean there's a risk of PBC in the future? I'll say from my own experience, when I've biopsied people with this condition, they have a little bit of inflammation around the bile ducts, but not real full-blown PBC. But I've stopped biopsying these individuals and generally just follow them for their alkaline phosphatase and then start treatment if they show signs of PBC based on their biochemistries. We really don't know if there's any benefit of starting starting treatment. And again, let me just clarify, UDCA stands for URSO, the primary treatment for PBC. So there's no data on that. We really don't know what to do in these cases, but individuals with positive AMAs but normal alkaline phosphatase definitely should be followed to look for the development of PBC. Next slide. And then within PBC, we have some variations in the condition that are important to recognize. So probably the most common one is just an antimitochondrial antibody negative PBC patient. This makes up about 10 to 15% of all PBC patients. There's some question about whether they have more severe disease. I think the data on that's not great. Typically they present the same way and have the same response to therapy. So not too much different there, just a little harder to diagnose. I'll spend a little time on the next slide talking about overlap with autoimmune hepatitis. Has anyone here been diagnosed with overlap with autoimmune hepatitis? Yeah. It usually is about 10% of PBC patients that get this diagnosis. And then there's another form of PBC we see very rarely, and it's called ductopenic. And ductopenic means just that the bile ducts are lost. And so we saw that slide before where there's inflammation of the bile duct and the bile duct's getting injured. Well, in some individuals, those bile ducts just get completely destroyed. And on the liver biopsy, we look and we just can't find any bile ducts or very few of them. And even though their liver disease, the fibrosis in their liver disease, the scar is not very advanced, they're missing their bile ducts. And that since those are gone, the liver can't get rid of bile, and that causes further damage. And these individuals tend to have horrible cholestasis or itching, as well as very rapidly progressive disease. Next slide. So a minute on the overlap syndrome, and I bring this up because we see it overdiagnosed frequently. And it can occur either in combination initially with PBC, or someone might have autoimmune hepatitis first and then develop PBC, or vice versa. But to make the diagnosis, the criteria we typically use is that in addition to diagnosis of PBC, you have to have really elevated ALTs. So PBC patients typically do have some elevation of their ALT, the other liver tests. But they need to be really elevated, more like in hepatitis. And then they should have other markers of autoimmune hepatitis, such as an elevated IgG, that's a type of immunoglobulin or antibodies, or this anti-smooth muscle antibody that we see in autoimmune hepatitis. And probably most importantly is on the liver biopsy, we have to show that there are signs of autoimmune hepatitis and not just PBC. And we really want to be sure that that's the case because the implication is if someone has overlap with autoimmune hepatitis, they have to be on immunosuppressants. And these are drugs that have, serious risks and side effects. And we don't want to start someone on treatment with these drugs unless we're sure of what we're doing. So typically what we'll want to do, unless it's quite clear they have more of an autoimmune hepatitis than PBC, we'll want to treat their PBC first with urso and then see how they respond and see if they need immunosuppressants. Next slide. Okay, so that's really quick, just going through diagnosis. So I don't know if people have had a chance to write down their questions or if we should move on. I'll let the MC guide us here.
If anybody has any questions, feel free to raise them up too, and we can. Yeah, do you have one, Yvette?
Down real quick, but just real quick, if you're in chemical remission with AIH, would you continue the immunosuppressants?
So with autoimmune hepatitis, there's what we call biochemical. So just so everyone understands, the question was about clinical biochemical remission with autoimmune hepatitis. Do you need to keep taking that medication? So as I mentioned, for autoimmune hepatitis, we use immunosuppressants which have side effects. And the criteria we use for treatment of autoimmune hepatitis is normalization of the ALT as well as the IgG. And we know that individuals that achieve that do very well. That's about half the patients with autoimmune hepatitis that actually achieve that. If we take away immunosuppressants, about half of those individuals will have a relapse. And then we have to retreat them with steroids typically to get them back in remission. So it's always a difficult question about removing immunosuppressants in autoimmune hepatitis. So it's not a yes/no answer, it's a discussion that we have.
We had one other question that was about presentations and sharing. We will, as you may have seen, we do have recording going on in the back, so there will be videos of this that we'll be posting some of this, as well as some of the presentations will be available as well. I see some more questions over here. Okay. We have a question here for Dr. Bowlus. Are there lifestyle changes that can be made to reduce the likelihood of progressing to PBC from just being AMA positive?
No, not that we're aware of. It's a very rare sort of situation, so not clear if there's anything we can do preemptively to prevent going from AMA positive to full-blown PBC.
Okay, and we have another question about biopsies. As far as being diagnosed within, say, 5 years, how frequently do you need to get biopsied?
We're going to talk about that in just a minute, but I would say you rarely have to get another liver biopsy unless something has changed in your clinical presentation, if you're just starting to develop other forms of liver disease, but pretty rarely would you need a second liver biopsy.
Good. And here's another good question about diagnosis. How long does it typically take, do you see, for patients to get diagnosed?
Great question. So it's really variable, and I think my impression is that it's taking less time. I think there's more knowledge out there of the disease. It used to be that people would struggle for years going around not being diagnosed. I still do see patients that, they get diagnosed and referred, and then we look back and we see their liver tests have been abnormal for years and just sort of, it's just a little elevation of the alk phos and not really worked up. So in the past, it used to be, I think, a delay in diagnosis of several years. Hopefully, on average, that's getting better.
Great. And we have another question that's on kind of biopsy versus fibroscan. Are they equal?
So we're going to talk about that again just in terms of staging. So they're not equal, especially in terms of diagnosis. So FibroScan does not help us with the diagnosis of PBC. In those cases we talked about, when you don't have the markers and you need a biopsy for diagnosis, a FibroScan can't substitute for that.
Okay. And what about tracking? You mentioned about autoimmune and PBC. What about with other autoimmune diseases and kind of that tracking or comparison?
So if you have PBC, then you're at risk for developing other autoimmune conditions. We know that autoimmune diseases tend to cluster in families and within the same individual. So if you have PBC, then obviously you and your physician should be looking for other autoimmune diseases such as thyroid disease, very common, the Sjogren's I mentioned, also forms of arthritis, a little bit increased risk of inflammatory bowel disease. Those sorts of things are to be looked for.
Great. And we have another question on NASH and PBC, the prevalence or what you're seeing in that area.
So NASH stands for non-alcoholic steatohepatitis, or a more general term is non-alcoholic fatty liver disease. This just goes along with the general population. So we do see fatty liver disease along with PBC. Most people that have non-alcoholic fatty liver disease don't have the more progressive NASH form of the disease. And so there's maybe a little bit of what we call steatosis or fat in the liver, but the predominant thing we would see would be the PBC features on biopsy. So that is sometimes where we do need to go is we have somebody that presents with more a fatty liver presentation, and we do some testing, and then we find the AMA, and the question is what's more important. And in those situations, a biopsy may be needed.
Okay.
I'll have to make a fifth route, I think, now to get to the diagnosis.
Exactly. And there's a question around kind of AMA and ANA negative. Is there still that same risk for developing autoimmune diseases?
I'm not sure I understand the question. If your AMA is negative and your ANA is negative, but you have PBC by biopsy, then yes, I'd say you're still at risk of developing all the other types of autoimmune conditions, despite the fact that those are negative.
Okay. We have a couple more, but let's go on to the next portion. Yeah.
Great. Okay. Next slide, please. Okay. So before we get into treatment, then, I just want to go over sort of natural history and staging of disease, and that's where we're going to talk about FibroScan. So the natural history of PBC is you get diagnosed, you have the antimitochondrial antibody. Dr. Gershwin's going to talk about that and what causes this predisposition to autoimmunity, what causes it. And then there's inflammation of the bile ducts, so the alkaline phosphatase goes up. As those bile ducts are damaged, bile gets trapped in the liver, it can't get out. And within bile are what we call bile acids. And bile acids are things that the liver produces. They go out the bile ducts into the intestine and help us break down fats and other nutrients in the intestines. But in the liver, they're in very high concentrations. In those high concentrations, they're acids, and they can do real damage. And so there's that secondary damage that occurs with the cholestasis. All that leads to scarring in the liver, fibrosis, and in the end stage, cirrhosis. When you get cirrhosis, then you get these vascular changes leading to what we call portal hypertension, the complications of cirrhosis, and eventually liver transplantation. Now, fortunately, this is not a path that most patients are going to take, but this is the potential path for people. Next slide. And then on top of that, even if you don't go down this pathway to liver transplantation, we have impaired quality of life. Outside of the liver, we have to think about fatigue, itching, and those can be unrelated to what stage or what path you're taking in terms of the progression of the liver disease. Next slide. And then so in terms of treatment, the best place to start treatment is in the early stages, when there's just an elevation of the alkaline phosphatase, when there's less damage to the bile ducts, and clearly before there's cirrhosis. Now, we can't always do that because some people aren't diagnosed till they have cirrhosis. But we don't want to delay treatment, particularly in the early stages, because people respond better to treatment in the early stages, and we have a better chance of stopping the progression of the disease. When we start treatment in the later stage of the disease, we slow the progression. The question is, how much can we slow it, and can we prevent these bad outcomes at the end? So knowing the stage of disease is really important in terms of understanding prognosis, how response might be, and how aggressive to be with treatment. So when we talk about staging of liver disease, what we're really talking about is the amount of fibrosis in the liver, the scarring in the liver. And we generally break it down into 4 stages. But you can imagine it's not like you're not taking a step each on a stairway. It's a progressive scarring in the liver. We just kind of like to break it up into chunks to think about it. So there are 4 stages we use, and the gold standard, the historic standard, has always been with liver biopsy. And we pretty much divide stage 1 and 2 into early PBC, stage 3 and 4 into late, or stage 4, which equals cirrhosis. And so if you've had a liver biopsy, you should be able to know what your stage was at the time of diagnosis. And that's really important to know. Are you early stage and you've still got a real good healthy liver, or you're later stage and we need to be a little bit more cautious about how we do treatment and be maybe a little more aggressive. Now, where FibroScan comes in and some of these other non-invasive tests is staging disease without having to do a liver biopsy. So most patients that don't have a liver biopsy because they had positive AMA, then we do a FibroScan to stage them to see what stage disease they are. And there's some other non-invasive tests that we can use also. There's some Rotterdam criteria that are just used on your bilirubin and albumin. Those aren't used too much, but they're specific to PBC. And then some other things we use in other liver diseases are the ratio of your AST to the platelets, and what's called an enhanced liver fibrosis test. That's now approved in the US for fatty liver disease. It's not approved for PBC. But these are things that also, they're blood tests that can pretty much tell us if someone has cirrhosis or not, really is what they're good for. Next slide. So FibroScan, which many of you probably have had, the generic term is vibration-controlled transient elastography. And essentially what it does is it measures the stiffness of the liver. As the liver gets more scarred, it becomes more stiff. And up on the top left, that's a report from someone that had a FibroScan. And each of those little pictures, those 10 pictures, is a different reading of the FibroScan. And we take the average of those 10. And it tells us 2 things. The blue number, the 240, that's called controlled attenuation parameter, or CAP, and that just tells us the degree of steatosis or fat in the liver. What's more important is the orange number, the 15, and that is the liver stiffness. And over on the right, that's from a study from Italy of about 120 patients with PBC that had both a liver biopsy and a FibroScan done. And on the bottom, the 1, 2, 3, 4, those are the different stages based on the biopsy. And then on the vertical axis, that's the liver stiffness measurement, or LSM, that's the FibroScan. So you can see in the first 2 bars, those are patients that have stage 1 or 2 by liver biopsy, and then their FibroScan data, or values. And they're pretty much the same, right? So FibroScans can tell you if you're stage 1 or 2, but you can't really differentiate stage 1 from stage 2 very well. So if you look at your numbers and you say, oh no, I went from stage 1 to stage 2, no, I wouldn't put too much weight on that. Even at stage 3, there's just a little bit of an increase over stage 2, and there's a lot of overlap. So even if you're at stage 3, like if you're at the lower end of stage 3, you still could just as easily be stage 1. Where it's really helpful is stage 4. Then you start getting some real separation. Now, the other point I want to make is you see the little dot in the middle of that graph. I don't know if you can see it from back there, a little circle. That's a patient that had stage 2 disease by biopsy, but is looking like stage 4 plus on the FibroScan. And we know that occasionally on FibroScan, we get these really erroneous readings that just don't make sense to us. So be careful if you have one of these FibroScans, especially if you have more than one, and your reading before was 6, and now all of a sudden it's 20, and it's only been a year and nothing's changed. The FibroScan is probably wrong. And it shouldn't, what we want to avoid is someone saying, oh no, now you have cirrhosis, we have to do a biopsy and see what's going on. And you get an unnecessary biopsy. So we want to be careful with the FibroScan and not overutilize it. And the reason I say that is because we did a study down here on the bottom right of 45 patients with PBC, and we did FibroScan as well as another test called MR elastography, which is even better. And we did this at baseline, after 1 year, and after 2 years. And in neither of those tests did anyone really change. I mean, I think out of the 45, 4 people changed in terms of the stage of their disease. So getting a FibroScan every year is probably not necessary. Every 3, 5 years, maybe, if you want to follow what your disease is. Otherwise, you're probably getting it too frequently and might just get more erroneous measures than are helpful. Next slide. Okay, so now we've got diagnosis, we've got your stage, let's start treatment. Next slide. So I'm sure you all know, and hopefully most of you are on ursodeoxycholic acid, UDCA, also known as ursodiol, is generic name. Brand names Urso Forte, Actigol, they're all the same thing. It's easiest for us to say Urso, but I'm not referring to the brand Urso when I say it. This is actually a naturally occurring bile acid. I have it, Dr. Gershwin has it, you all have it. It's something we have, it's just a minor bile acid, but it's the primary bile acid in bears. Those of you that know Latin, Urso, bear. And so what we're doing is we're basically supplementing the bile, the pool of bile acids that we have in our body. And ursodiol helps to thin the bile, allows the bile to flow more easily, it protects the bile ducts, but it really has no immunosuppressant effects. It's not treating the underlying autoimmunity that causes PBC. It's just preventing that secondary injury from the cholestasis, the backup of the bile into the liver. The dose is based on your weight. It's in kilograms, so if you can convert your pounds to kilograms, multiply that by 15, or add half of it to it. I'll get you there. Anyway, 15, that's how much total urso you should be on during the day, and usually we divide it into 2 separate doses. So if you're good at math, you can figure that out. If not, I use my calculator. It's a relatively safe drug. We've used it for decades. Some people do suffer from side effects that are rare. GI upset is probably the most common one that prevents people from taking it. About 6-7% of people with PBC just can't tolerate urso. There have been reports of hair loss with it, although patients with PBC often have some alopecia or hair loss, so to me it's somewhat questionable how much of that's due to urso versus just disease, and then also weight gain's been reported in some of the clinical trials. The true benefits of urso are that, number one, it improves liver tests, but big deal. But more importantly, it reduces the risk of progressing to liver transplantation. That's clearly been shown. So there are real benefits of it long term in terms of patients doing better. Unfortunately, it doesn't improve any symptoms. Doesn't make itch better, doesn't help fatigue, it doesn't help with any other symptoms. So it slows the progression of liver disease. Next slide. And what's really become apparent is that about 60% or so of patients that take urso do really, really well. And that's based on whether they have what we call a biochemical response. And this is a new sort of thing that we look at now after we start treatment with PBC is, does someone have a biochemical response? This is one of the first studies back in 2008 from the French group. And what it's showing is that patients, after 1 year of treating them with urso, if they had this biochemical response, they had a survival that was similar to a group of people their age. So that top purple line, the solid line, are PBC patients that had a biochemical response to urso. Over 15 years, a very small percentage of them died or had a liver transplant. And that dotted line that follows it, that's a group of patients of similar age and gender, followed for the same period of time, and their risk of death or liver transplantation, they're identical. And in fact, in some studies, the PBC patients actually do better than the control group. The blue group are the PBC patients that didn't have a biochemical response. So if you take urso for a year, you have a biochemical response, your life expectancy is the same as anyone else. If you don't have that biochemical response, then you're still at risk of progression of your disease. Next slide. Now, there are a lot of different criteria that have been published over the years as sort of like, are you a responder or are you not a responder? And it's not quite that simple. It doesn't mean that you're not getting benefit from urso if you don't have a complete response, a biochemical response, but it may just not be enough. And so we've gotten a little more sophisticated in looking at, what is the relationship between the response, the degree of response, and the risk of going on to having a transplant. And so this is data from a large international consortium of like 5,000 patients, looking at that relationship between alkaline phosphatase and risk of liver transplant or death, and bilirubin levels in liver transplant and death. And so if on the left-hand side, this is alkaline phosphatase levels after 1 year of treatment. And the one on the numbers on the bottom are the multiples of what we call upper limit of normal, the regular reference range of alkaline phosphatase. So if you're 1, you're still within the normal range. You're 1 or below, you're in the normal range. If you're above that, then you're elevated, and you're twice the upper limit, 3 times, 4 times the upper limit of normal. And you can, and then the vertical axis is the risk you have greater than the normal population without PBC. And if you're at 1, your risk is the same. There's no difference. So you see that blue line, the solid blue line, up until you hit 1 times the upper limit of normal, you're basically the same risk as a non-PBC population. As soon as it gets above 1, there's an increase. And it slowly increases the higher the alkaline phosphatase is. So there's this relationship, even if you don't have a biochemical response or you don't normalize it, you're still getting benefit if we can push that alkaline phosphatase as low as possible to get it as close to normal as we can. On the other side, on the right, we see a similar thing with bilirubin, but it's a little more pronounced. A couple things about that. You'll see that the curve is steeper. So bilirubin is more important in terms of when it becomes abnormal because that represents the loss of bile ducts. And you also see that the point where it goes up is shifted to the left. It's lower than 1. So if your bilirubin is still normal, but it's the upper end of normal, so it might be 0.9, 1, there's already an increased risk there. And so bilirubin is another thing that we really want to pay close attention to in terms of when that starts to get abnormal, because that's another sign of increasing risk. But this is what we're trying to do. We're trying to get these things as close to normal as we can with the therapies we have. Next slide. And if we really want to get sophisticated, and you can all do this, is you can calculate your globe score. And this is a model based on, again, those same patients that I just showed. And you put in your age, your bilirubin, your alkaline phosphatase, your albumin, your platelets, and the normal values from the lab you had them done at. And you should have been treated with urso for a year. Probably works if you've been treated for longer than a year. And then what it does is it calculates your transplant-free survival, that is your chance of surviving without liver transplantation at 3, 5, and 10 years. And then it compares it to a group of individuals about the same age of the individual that puts this in. And it tells you whether there's a statistically significant difference between the survival between those two groups. It's important to recognize that this is based on, the normal population is based on the population in the Netherlands. So it might be better than our population, but it will give you an idea of, well, my risk is the same, so maybe I don't need another treatment, whereas, well, my risk is higher, so maybe I ought to think about these second-line therapies. Next slide. Okay, so treatment of PBC. We start with urso, normal alkaline phosphatase, normal bilirubin. After 6 to 12 months of treatment, continue the urso, have labs checks a couple times a year, especially if you're early stage. See me once a year, twice a year if you want, to talk and chat. That's fine. But it's really boring. I mean, this is 60% of the patients, right? We just sit and chat. I mean, discuss other symptoms. We're not worried about them needing liver transplant. Itch, fatigue, still a problem. And hopefully we'll have some better things for that. But right now, in terms of preventing progression of the liver disease, we're good. Next slide. So after 6 months to a year, the alk phos is still elevated or the bilirubin's elevated, particularly in those that have advanced fibrosis. Then we're thinking about second-line therapies. Next slide. Or occasionally someone's intolerant to urso. They just can't take it. Nausea, just can't get them up. They can't take the full dose. Then we think about second-line therapies. Next slide. So currently these are what we have to offer in terms of second-line therapies. Not a lot right now. The only approved therapy in the United States or anywhere is obeticholic acid or Ocaliva or Ocaliva. Someone correct me on that one. I always get it wrong. Obeticholic acid. The other option are fibrates. In Europe and Japan, fibrates have been used extensively, and there's a really good study that came out from France using bezafibrate. for the treatment of PBC and showed how effective it was. I'll show you a slide on that. In the US, we have something called fenofibrate. These are old drugs that have been used to treat elevated cholesterols and triglycerides. And there are people in the US that have used fenofibrate quite a bit. There's just not a lot of reports on it. And it is off-label use for the treatment of PBC. And then the third option really is clinical trials. Next slide. So not to get too into the weeds about how obeticholic acid works, but unlike URSO, which just sort of dilutes out the bile acids, obeticholic acid works by targeting a protein, a receptor that binds to bile acids and regulates how the liver makes bile acids. So what it does is actually turns down bile acid production by the liver. And it's much more potent than sort of just diluting out the bile acids like URSO does. Next slide. And so the way obeticholic acid got approval was through this study called the POISE trial. And it was a one-year study in which it was what we call double-blind, meaning the investigator and the patient, they don't know what they're getting. There were 3 different groups of patients. Some got placebo, some got the obeticholic acid at 10 milligrams. Some started at 5 milligrams, and then they could increase if they didn't have an adequate response. And that went on for 12 months, and then everybody got the medication open label, meaning everybody knew they were getting the medication. Next slide. And what the goal of the study was to have this response, which was defined as having the alkaline phosphatase down to a level that is about 200, and it had to drop by at least 15%, and the bilirubin had to be normal. You had to have all those 3 things in order to be considered a responder. And what the graph is showing is in the orange and blue bars are the 2 treatment groups, either the 5 milligram in orange or the 10 in blue. And the white bar are the people that were on placebo. And you can see by the end of 12 months, about a little more than 45% of patients that got obeticholic acid achieved that biochemical response, whereas only about 10% of the placebo group did that. And then when the placebo group got onto the medication, the obeticholic acid, they all had a response. Next slide. And this has been going on for many years now. People have been on obeticholic acid for probably almost 10 years for some patients. And that biochemical response shown up on the top, they all maintain it. And on the bottom is the alkaline phosphatase. It drops down and it stays down for a long time. Next slide. Now, one of the questions that we've been trying to answer with obeticholic acid, just like we did with URSO years ago, is yeah, it makes your liver test better. We think that means you're going to do better, but does it really show that? Within POISE, there was a small group of patients that had liver biopsies before they started medication, and then after at least 3 years of being on obeticholic acid. Next slide. And what we did was we did some very sophisticated imaging of the liver biopsies to quantify the amount of scar in the liver. Aside from someone just looking at the slide, did some sophisticated imaging that has lots of different parameters of the type of fibrosis, the network of the fibrous tissue. Next slide. And gives us nice pictures. And then this was the result. So on the top panel, these were the biopsies before starting medication. The bottom panel is after 3 years of treatment. And each row is a different metric of the fibrosis. And then each little cell within that is how severe was that metric in that individual patient. Green being good, red being bad. And so from left to right, 1 through 16, each one of those columns is an individual patient. So on the left-hand side are patients with early fibrosis. They're green, right, a little yellow. And at the top is at baseline, and the bottom's after treatment. So no one really progressed. They all stayed early. No big deal. On the right-hand side, those are the patients that had more advanced fibrosis. And you see the red ones at baseline got less red after 3 years of treatment. So this was some evidence, at least histologically, at least in the liver, we're seeing some improvement in the fibrosis in the liver based on these small number of patients using this technology. Next slide. What's recently come out is comparing people that were in the POISE study to what we might call a synthetic control, right? Everybody in the POISE study was getting, after 1 year, was getting obeticholic acid. There was no control group to say, oh, they actually did better. So what we've done is go back and look at different groups of patients previously, historically, who only got URSO, but otherwise looked just like the patients that were in the POISE study, and say, well, did the patients in the POISE study do better than we would expect based on these historical individuals, so-called real world? And there are 2 different groups of these control patients. There's the global PBC group and a UK PBC group. And on the left-hand side, this is transplant-free survival, that is alive and not needing a transplant. And the blue line represents the patients that were getting obeticholic acid in the POISE study, and the red represents the group of patients from that historical control that only got URSO. And you can see that the POISE individuals did better than the control groups in both situations. And then over on the right, the differences are greater because we're looking actually not just at transplant, but did you have what we call hepatic decompensation? That is, before transplant, you were getting sick from your liver disease. You're having ascites or variceal bleeding or other complications related to having cirrhosis. So more evidence to suggest that treatment with obeticholic acid actually leads to improved outcomes of patients, which is what we really want. So data is starting to accumulate on obeticholic acid actually having some real improvement. Not a cure by any means, but some meaningful improvement. Next slide. We have to talk about concerns about obeticholic acid. Number 1, pruritus, a real side effect of the disease. In the study, 68% on the high dose had pruritus compared to 38% on the placebo. Only 10% stopped because of it, though. So most patients that take obeticholic acid, pruritus doesn't stop them from taking it unless they've already got baseline bad pruritus. Those are the individuals who just can't use it because they won't tolerate it. But the pruritus it's not irreversible. So if you're considering obeticholic acid, well, I don't know about the itch, try it. If you get the itch, you stop, and itch goes away. There are some cholesterol changes. Clinical significance of that's not clear. And we really have to avoid it in cirrhosis with portal hypertension. Next slide. This new FDA warning came out, not that new anymore, but we can use it in cirrhosis, but there can't be any portal hypertension. No big spleen, no low platelets. If you're on obeticholic acid and you have cirrhosis, talk to your doctor, make sure you don't have portal hypertension. You should not be on it. It's absolutely contraindicated now. Next slide. Let's see, how much time do we have? Again, another 10 minutes?
Yeah.
Is that right?
Yeah.
Okay. I'll go through these pretty quickly here, because these are not, so we have the fibrates, the bezafibrate in Europe and other places, and then fenofibrate here in the US. And then there are some other related drugs that are PPAR agonists that fall in the same category that are in clinical investigation now. So I just want to show some data on these. Next slide. So bezafibrate, again, this is not available in the US, but a similar study to the POISE study with obeticholic acid was done there. There were some differences in terms of the patients that were included in the study and the outcomes, but it had very good effects in terms of 35% of patients or so having this biochemical response compared to none in the placebo group. Next slide. There are some potential safety concerns about fibrates that are still being worked out in terms of some patients get elevations of their liver tests. There are some potential muscle effects, and creatinine, the kidney function test, tends to go up, but the kidney function seems to be okay. So something that just needs to be monitored. Next slide. The really nice thing about these drugs, though, I'm sorry. This just shows 2 drugs that are in trial right now. They're both in phase 3 study right now. That's elafibranor and seladelpar. They both drop the alkaline phosphatase really nicely. So hopefully in the next couple of years, we'll see these be approved. Next slide. What's really nice about bezafibrate and what's shown with seladelpar recently is these drugs help with itch. They don't cause itch, but people that have itch, they actually work really nicely. On the left is a study that was done with bezafibrate, which included both PSC and PBC patients. If you, on the top slide there, this is just looking at what we call it's a score for itch that people do, and about half the patients had at least a 50% reduction in their itch when they got bezafibrate compared to 10% in the placebo. And it worked whether you had PSC or PBC. And then in the seladelpar study, patients weren't enrolled based on itch, but those that had moderate or severe itch, many of them had improvement in their itch, shown in the green bars over on the right. Really something that would be better tolerated than obeticholic acid potentially and have some benefit for patients with itch. Next slide. So just finally, these are the clinical trials that are currently open for patients that have an incomplete response excuse me, to urso. There's a combination of obeticholic acid and bezafibrate going on right now, so trying to combine these two things, which would be very interesting and see if there's a benefit there. There's, as I mentioned, the elafibranor and seladelpar phase 3 studies have closed, but there's another phase 3 study, the seraglitazar, that's currently open for PBC, so a third one there. There is a seladelpar study open, but for people with sort of advanced liver disease to see if it's safe and effective in those cases. You're going to hear about this CNP 104 study, which is really interesting in terms of going after the actual underlying autoimmunity. And then there's a study going on for patients with fibrosis using antifibrotic to try to prevent progression or even cause regression in those individuals. So really interesting time for PBC, I think, in terms of trying to slow the progression from different perspectives. Some of it old school of just going after bile acids, some of it newer going after the inflammation in a very specific way or the fibrosis. Next slide. So new therapies to come. There's still lots of unmet need. I know Dr. Levy is going to talk about itch later. Fatigue remains an issue that we really don't understand. And I didn't talk about other issues that you should be keeping in mind with your physician in terms of screening for thyroid disease, check your fat-soluble vitamins. If you have Sjogren's or just dry mouth, make sure you keep up with your dental care. We see PBC patients losing teeth unnecessarily, so keep on top of those. Last slide, I think. And just for reference, this is kind of the checklist of all these things we talked about, and I think they'll be shared with you. So I'll end there so we have time for questions. Thanks.
Thank you, Dr. Bowlus. And a couple other questions. So you mentioned during the discussion kind of about clinical trials and placebos. There's a question here about kind of, obviously with the need for early intervention with PBC, what's your thoughts on the aspect of synthetic controls and the use of them, in some of these clinical trials?
Wow, that's a sophisticated question. Okay. So one of the problems we have in all of liver disease, and in chronic diseases in general, is proving that a therapy actually has a clinical benefit. Think about diabetes, right? Diabetes people have for years and years and years before they develop kidney problems, eye problems, all these other things. Well, to get approval or really think that a drug works, you don't have to prove that you prevent those things. You just have to show that you improve the hemoglobin A1C, the A1C which has been validated, over decades to show that if you improve that, you improve the outcome. So you no longer have to do a 20-year study. You can do a 1-year study, 2-year study, and show that. In liver disease, we don't have that. In PBC in particular, we have these, what we call reasonably likely surrogate markers of clinical outcomes, which just means if we improve that alkaline phosphatase, it's reasonably likely that it will improve these outcomes we're interested in, that is preventing liver transplant and death from liver disease. But to really know that, we've got to run a trial for many, many years to show that there's an actual difference between people getting placebo and people getting the drug. And that's what was the attempt with obeticholic acid. So the POISE study was done for 1 year, and then everyone got the drug, but it didn't show that those individuals actually did better. So there was an attempt to do a study enrolling patients with advanced disease. Some got placebo, some got drug. But the drug's already available on the market, and if I think it does something, why am I going to go in a study and risk getting placebo? And what we saw were people dropping out of the placebo, or dropping out of the study, particularly because they didn't see any improvement in their liver tests. So it's like, well, obviously I'm on placebo, I'm going to go get the drug. And so the study had to be stopped because it just couldn't be done. So we're left with the next best thing, which is using these synthetic controls. And it has to be done right. You need to make sure that the group you're comparing, the two groups, are equally matched for everything else. And there's not something different that might be attributed to these diseases or these outcomes other than the treatment. And so it's the best we can do. It's not perfect, but I think it just, you start stacking the circumstantial evidence on top. You improve the liver test, you improve the histology, you improve outcomes based on this synthetic control. I think if it all points in the right direction and you have overwhelming evidence, then I think we can feel very confident that it's a real effect that we're seeing.
Great, thank you for that. And another question around the aspect of, you talk in the beginning about diagnosis and biopsies. As you look into the aspect of changing treatments or modifying, in this case is specifically regarding AIH, do you recommend changing or getting the biopsy before you change some of those immunosuppressants or other drugs?
Yeah, so I think management of AIH, whether it's in PBC or with PBC or without it, is a whole nother animal. And biopsy really does need to be done more frequently because the liver tests don't always reflect what's going on in the liver itself. So oftentimes when we want to withdraw therapy or reduce therapy, a biopsy is helpful to understand if we can do that successfully. So sometimes it's necessary, yeah.
Great. And you touched on it a bit with some of the other conditions that are frequently managed alongside. What about cholesterol and kind of the elevation of that? And the aspect around, they want to know a little bit more around real cholesterol. It's not, it's not real cholesterol.
Yeah.
What's your thoughts
So it's
on
real,
that?
it's not imaginary cholesterol. It's real, it's a different cholesterol, but it's real. So this is always a tough one in terms of management of cholesterol because it's frequently elevated, and it's not uncommon that people get their liver tests because they've got high cholesterol and they're getting started on a statin. And I don't think we have the perfect answer. What we do know is that there does not appear to be an elevated risk of heart disease in PBC patients, despite the fact that they have elevated cholesterols. On the other hand, that doesn't mean you're protected from having heart disease, and I know plenty of PBC patients that have heart disease, and that's been their major problem. And we know that PBC patients more frequently have a history of smoking, and that's a risk factor for heart disease. You might have a family history of heart disease. So there clearly are indications when patients with PBC should be treated for their high cholesterol. And we also know it's very safe to use a statin in PBC. So there's no increased risk of liver toxicity or anything else. And in fact, there's some evidence to suggest that statins are good for the liver in lots of different conditions. And in fact, in Sweden, they're starting a large study of PSC using statins based on some of their data. So there shouldn't be a fear of taking statins and treating the cholesterol if your primary care physician thinks you should do it.
Awesome, thanks for that. And there's a couple questions around line of treatment. You mentioned kind of first line treatment and second line treatment. Can you kind of briefly describe like the difference between a first line treatment and a second line treatment?
Yeah. So first line just means upfront what you should get as soon as you get diagnosed. So everybody with PBC, once their diagnosis, there's really no question about what you should be treated with. There's no option A, B, and C to choose from. You should be started on urso. And then based on the response, based on the tolerability, then you go down and think about other therapies. And even there, we're kind of limited. And so those are the second line therapies. That's when we're talking about obeticholic acid, fibrates, clinical trials. So hopefully in the next few years, we'll have more options in that second line, a little bit more of a menu to choose from, but right now we're still limited.
Great. There's a question around adding a line of therapy. And, obviously everybody's not going to you or to Dr. Gershwin or, some of the key thought leaders. How do you approach that aspect of when to or how to talk through, am I doing enough?
I'm sorry, what was the first part of that?
As far as like adding a second line treatment, when do you or how do you approach that with a doctor that, is less educated on this area?
So I think what we see frequently is someone's not having symptoms, they're taking the urso, their alkaline phosphatase is stable at 250, 300. And so a physician that's not aware of this may think, oh, that's adequate, they're not having symptoms, et cetera. So I think it's important to say, to either seek out a second opinion, go to an academic institution, find a hepatologist, or address it with your physician and just say, this is not adequate. bring that AASLD guidance in with you to the office and show them. Don't tell them I Googled it. Not the right way to start the conversation.
Well, that's an interesting point too. I was going to ask on kind of a sidebar and how you educate your patients. You're obviously not giving each of them the full lecture that you're giving us, which is great. But how do you educate them, and or how would you encourage someone to ask questions to their team, if they're uncertain about some things?
So, well, I think, these sorts of groups are great. I think that there's opportunities for smaller groups to get together. I mean, we do that in Davis and have people that don't see us in clinic and have those opportunities to ask questions and get help. But I think that, you bring it up with your primary care doctor, you bring it up with your gastroenterologist. There's someone out there in your community likely or nearby that's knowledgeable, and really seeking that expert hepatologist should get you there.
Great. There's a question around, medications and how frequently a day to take them. This is specifically regarding URSO.
Yeah.
Taking it 4 times a day versus 2. Obviously, I know the.
Right. So,
but what's your
thought?
This
is not uncommon. So, the Urso Forte is the one that's labeled to take twice a day. The others not necessarily have the label for that, but we often prescribe them as twice a day just because we know 3 times a day people forget that 3rd dose. 4 times a day is, if you can do it, and that's the only way you can get that amount of Urso in because you have side effects, that's fine too. Some people take it once a day because that's the only thing that works for them. So all those are possible. I would be ideally twice a day, but whatever works so that you get the Urso in and you get the effect. If your liver tests aren't coming down, then try something else. Or if you're taking it once a day and they're down to normal, do that. That's fine.
Great. And I guess, you mentioned about some of the medications, some of the clinical trials. What about the aspect of supplements and vitamins? Do they make a difference?
Yes, there's not really much evidence on supplements or vitamins in terms of having any benefit. There's, some thought about vitamin D perhaps being beneficial. You should have adequate vitamin D, but better to get it through your diet, but a supplement if you need to, particularly if you have more advanced disease, you're not absorbing the fat-soluble vitamins. But other than that, I try to avoid most supplements. Rarely they have bad side effects. You don't know what's in them. They're not regulated. So I try not to encourage those.
Great. And during the discussion, you mentioned kind of the staging and understanding where someone is. As far as getting to further along in staging, such as stage 4, what's the importance of FibroScan or the biopsy? Is it still important? And what's your thoughts around that?
So again, I don't recommend doing biopsy to stage disease, right? So biopsies give us 2 things. They help us with diagnosis and stage of fibrosis. For PBC, most of the time we have diagnosis without the biopsy. So we don't need a biopsy for diagnosis. And now for staging, we have FibroScan, which is a pretty good replacement for biopsy. So I really don't, So when we're talking about staging of disease, fibrosis is fine. And where FibroScan works the best is at those later stages. So if your FibroScan shows that you have stage 4, you have platelets that are going down, you have a spleen that's getting larger, FibroScan shows it again. You've got stage 4 disease. Your bilirubin's up to 1.1. You've got stage 4 disease. I don't think you need a biopsy to prove that.
Okay. Yeah, so the FibroScan still is useful, though it's stage 4.
Absolutely. Yeah.
Yep. Okay. And as far as medications at that stage 4 as well, any thoughts on kind of the importance of continuing medication, URSO, fibrates, whatever you may be on?
Yeah, so as the disease gets further along, it's really important to try as much as possible to stop progression. But at the same time, as the disease is too advanced, then we have to be a little bit careful and not be too aggressive. And, and I mean, the main thing is with obeticholic acid, we talked about, don't use that when you've got portal hypertension. I'd say the same about fibrates and other things. We have to be really careful. And, it may, at some point, you just sort of say, okay, transplant's in your future. Use the URSA, we know it's safe. We can kind of put it off maybe, but if you're 50, you're stage 4, your bilirubin's 2, you've got portal hypertension, you're going to get a transplant at some point. It's just I mean, we have to accept that and not try to do things that might cause more problems.
Great. Thank you.
We're going to end on that? We're going to end on that? Come on. Something more hopeful.
No, as far as partnering with, your physician, you mentioned kind of seeking out other advice. How do you try to help, your patients as they come in and start? How do you build that relationship to make it an open communication and not make it so one directional or just taking direction? It's more of a conversation.
Yeah, I don't know if I have an answer for that. I mean, I think you're not going to, there are physicians that will partner and work with individuals, and then, and I think you see that over time as maybe there's more of a collaborative as opposed to paternalistic relationship.
Yep.
And, I don't have a way to change the way a physician practices or interact with their patients. So I think, it all depends. It's how you interact with people. I mean, it's very basic. It's
Sure.
I have nothing more to say.
Sure.
I don't know.
Well, one last question, I guess. A great opportunity here is for people to talk to other people. And, what's your thoughts around comparing yourself to others? As far as this happened to her, him?
Yeah, actually, I just had a patient who came down a couple hours drive to be seen. This was on Wednesday, and she came with her husband, and she's got early stage disease. Her liver tests are normalized, but she has bad fatigue. But she's sort of become isolated, and just hearing all the stories of everybody else that's looking at liver transplant and everything else. And one of the first things I said after we talked was, you're not going to need a liver transplant. She's 70, liver tests are normal, early stage disease. You're not going to need a liver transplant. It was like this huge relief, just like, And she still has the fatigue and other things, but I think that is part of it, is understand that this is not one disease, right? Everybody experiences it differently. There are the 40 and 50-year-olds that we see that have horrible disease. We can't get them under control. They already have cirrhosis. They're itching like crazy, and I mean, those are, that's different than the patient I saw on Wednesday that's 70 and, while she's got fatigue, doesn't have to worry about that liver transplant at least. It just needs to make sure she keeps taking it. So I think it is important that we hear each other's stories and how we're dealing with it, but not necessarily think that therefore that's my story, right? So,
Great point.
So I think it's good to share and take it all in, but understand what you're feeling.
Everybody's unique.
Yep.
Awesome. Great. Thank you, Dr. Bowlus.
All right, thanks.
Appreciate it.